And if you could just keep your microphones muted, that would be great, and use the chat for questions. If you haven't been to one of our meetings before, we are going to have a couple of presentations, which we're really excited about, and we're going to do a Q&A for those presentations. So if you could just stick your questions in chat whilst you're listening, we will come back and try and get through as many as we can. We have scheduled a short comfort break in the middle, just so that you can pop out and get a drink, pop to the toilet, whatever you need to do. And as I'm sure you're aware, we're obviously covering quite sensitive topics in these meetings, and I know you would all be very respectful anyway, but just to flag, and if anybody does need to step away from the screen, that's obviously completely fine. So I'm not going to say too much about the network. Hopefully you're familiar, as you've arrived here today, that we are focused on developing our understanding and our interventions for adolescent depression and creating a stronger network that we can all work together in. So just to highlight a few of our core network members. So myself and Victoria Pyle, who's about to take over in a second, are coordinating the network. And then we have a fantastic team around us. So Georgia Herring, who's going to be presenting some findings from the lived experience data today, as well as our other core members. So Miriam Odes, Stella Chan, Shelley Reynolds, and Alex Bullard, who can't be here today, unfortunately, is also one of our other lived experience members. And then obviously we have all of you. So thank you so much for being here. I don't think I missed anyone there. I wasn't reading the screen whilst I was talking, so I hope I got everyone. So I'm going to hand over to Victoria, who's going to talk through the structure for today.
Thanks, Bea. So just to tell you first a little bit about our approach for this network. So really our focus has been on trying to generate testable solutions. So we're kind of aware that several groups have conducted priority setting exercises in this area. And so what we wanted to do is take that really good work and then identify 3 priorities and now begin to co-develop testable solutions and think about research agendas to move forward. And so we use the James and ADvaNCE priorities to independently rate the priorities, and then came up with 3. And then how we want to co-develop is through including young people with lived experience as a key part of our core group, having the survey to consult young people on these priorities, which Georgia will tell you much more about, and then also the workshops, so where we hope to brainstorm possible solutions with you, so people from different disciplines and with different experiences. So our 3 priorities focus on 3 different areas, but all strongly related to a young person's experience of depression. So starting with identification, so that was our previous workshop back in June, then to today, which is about intervention, and finally in September, we'll think much more about how to empower young people to manage depression. So this is what we're going to cover today. So we'll start off with 3 really exciting presentations. So first of all, Briony Gee from Norfolk and Suffolk NHS Foundation Trust and the University of East Anglia will talk to us about intervening with mental health difficulties in school. Nick will then tell us about depression online treatment study, and Nick's from UCL and the Anna Freud Centre. Georgia, as Faith said, is our lived experience researcher and will tell us about the ADvaNCE survey findings. We'll then have a very quick break before coming back together to go into breakout rooms, and then finally come back together for a whole group discussion on the suggestions that we've generated. And I think, yeah, so that just leaves me to pass over to Briony for her first presentation. And just to say, actually, I don't know whether Faith mentioned it, but the Q&A will be after Nick's presentation. So we'll do a Q&A for both Briony and Nick.
Great. Are my slides showing up okay?
Yeah, they look perfect.
Yeah, lovely. Okay. Well, thank you so much to Victoria and Faith and the other network members for inviting me to speak today. So I've been asked to give a very quick run through of a couple of reviews that we did a couple of years ago now, looking at indicated mental health interventions delivered within schools and colleges. And the motivation for this work was recent policy changes here in the UK, where the Green Paper on transforming mental health care for children and young people place an increasing focus on schools as a setting for early intervention and treatment for young people experiencing mental health difficulties. And we noted that there'd been a couple of recent reviews at the time focusing on kind of universal or preventative interventions delivered within schools to prevent young people developing mental health problems. But there hadn't at the time been so much done focusing on interventions for young people who are already presenting with some symptoms of mental health problems and delivering those kind of more treatments within schools. So I thought it would be useful to look at those. So the first review I was going to talk about focused on the effectiveness of those interventions, and that work was completed with a couple of network members, so Dr Faith Orchard and Professor Shirley Reynolds, as well as some colleagues from UBA and NSFT. And what we did is we did a systematic review and meta-analysis of randomised controlled trials, and we included studies of indicated psychological interventions delivered within schools or colleges to young people between the ages of 10 and 19, so that's sort of adolescent age group, with elevated symptoms of depression or anxiety. For the talk today, I'm just going to be focusing on the depression side of that review. So we searched 8 electronic databases and we identified 45 eligible trials in total. And of those, 31 were focusing on depression. So they'd screened young people in on the basis of having elevated depression symptoms. So we pulled together the findings of those trials that we'd identified to see, do these interventions seem to be having an effect on symptom severity? So for depression symptoms, this was the forest plot. So taking all of the studies together, the pooled standardised mean difference came out as 0.45. There was, though, quite an outlier. So once removing that, it brought it down to 0.34, I believe, the pooled effect size. So I think, yeah, we can be confident that there seems to be a small effect on depression symptoms of indicated psychological interventions delivered within schools immediately post-intervention. That's what this was looking at. We did also then look at longer-term follow-ups. And at follow-ups less than 6 months, the effect did seem to be sort of sustained. There's some evidence of that. Once you got beyond that, so studies that had looked 6 to 12 months or 12 months or more, the effect was then non-significant. But we were looking at fairly small pools of studies at that point that had those kind of long-term follow-ups. So I think longer than 12 months, there was only 3 studies. So I think that points to probably needing more work to look at the longer term effects of school-based interventions. We did some subgroup analyses as well to kind of explore the heterogeneity in the results that we were finding. There are a few kind of interesting things I just wanted to mention. So one of the things we thought was quite interesting was that for the subset of studies where internal school staff had delivered the interventions, that was one of the few subgroups where the pooled effect wasn't significant. So we thought that posed some kind of interesting dilemmas in terms of perhaps it being sort of more feasible to maintain an intervention that's delivered by internal school staff, but potentially less effective than interventions delivered by external staff coming in. Also wanted just to point out that when we looked at types of interventions, there seemed to be a bigger effect for IPT-based interventions than CBT-based, although there were a much smaller number of studies. So I thought I would use that as an opportunity to quickly plug a study that we're in the middle of at the moment, where we're looking at a kind of condensed form of IPT, interpersonal counselling for adolescents. So the idea is that that's a therapy that can be delivered by people without kind of specialist training. So the kind of existing youth workforce are trying to kind of upskill them to deliver IPC. So we'll see how that goes. The second review that we did was focusing on the feasibility of delivering these interventions within schools. So we're interested in exploring what might the facilitators and barriers be to delivering these sorts of mental health interventions within schools and colleges. This was not focused specifically on sort of depression. It was all emotional difficulties we were looking at. But I think most of the lessons would kind of generalise across mostly fairly general. So this is another systematic review, but this time it was a thematic synthesis. We were trying to basically draw together the lessons from across various papers. A lot of what we were synthesizing were kind of informal author reflections rather than kind of systematically collected qualitative data. So I think that's quite an important limitation to note. But yeah, it's kind of interesting, and I think fairly common sense findings were coming out of it. So from the databases we searched, we identified 50 eligible studies to include. So these were the themes that were developed out of that, and we kind of organised them into this model. So the things that seem to be important in whether school-based interventions can be successfully implemented are the characteristics of the intervention itself. So is the intervention acceptable to young people and staff? Are the components practical to deliver? All very common sense. Group format interventions seem to be easier to deliver and sustain. And really importantly, can the intervention be flexed to fit around the existing school routines and timetables? We identified some factors related to organisational capacity, so the way that the kind of school is set up, the relationship between staffs, importantly, the support of the senior leadership within the school, some issues around kind of the wider school environment and how supportive that is to mental health, so that kind of more whole school approach. And logistical issues came up again and again as barriers. So yeah, just sort of very simple things like finding a room to deliver an intervention in, very important. The quality of the training and supervision that's offered to staff seems to be important, and the provision of suitable materials and manuals to support the fidelity of intervention delivery. Some factors related to provider characteristics, so the kind of suitability of the staff to deliver the particular intervention. And then we also identified some broader community factors as being important, so related to mental health stigma and the priorities of health and education systems, and the extent to which those two things kind of lined up with each other or not. So that was my very quick run through, and yeah, be very happy to answer some questions when we come to that point. Thank you.
Brilliant, thanks so much, Briony. Nick, shall we just quickly hand over to you if that's okay?
Yep, sure. Let me just share my slides. Just so not to stop and have a chance to process such an interesting presentation, but I know.
Yeah, I know.
Come back to that.
Yeah, and do put any questions or anything in the chat as we go along, both Nick and Briony.
Is the screen visible for people?
Yeah, looks great.
Great. So yeah, I'm just going to talk very briefly about what we call the DOT study, Depression Online Therapy Study. Just to give a bit of background, I think I don't need to speak to the audience here about the importance of tackling depression in adolescents, but in terms of my own research background, I began working with Shirley Reynolds and others on what was called the IMPACT study, which was a clinical trial evaluating 3 psychological therapies for young people with quite moderate or severe depression. And I was particularly involved in the qualitative work on that study. We co-produced 2 short films with parents and young people about their experience of depression and seeking help. And I think one of the things that really came across in that work with them was their sense that they felt they were in a way the lucky ones because they had actually managed to get to a child mental health service. And their concern was about all of the young people who would never get as far as seeing and having an opportunity for psychological therapy. And that really stayed with me. And obviously during the pandemic, this question of how are young people going to be accessing mental health services became even more of a priority. And I've been following for a couple of years some work that colleagues have been doing in Sweden, evaluating an internet-based psychodynamic treatment for young people with depression. And just the same month that the pandemic and the lockdown began, their first small clinical trial was published. And I was really struck by the results they had, really quite good results. And so we felt, given the pandemic as well, that we'd move forward our plans, and we wanted to try and adapt this program to a UK context and try piloting it here in the UK. So very briefly, internet-based psychodynamic treatment. It's based fundamentally on the ideas of someone called Malan and his triangle of conflict. It's very much an affect-focused program. It involves 8 sort of chapters which are released over a 10-week period. Each chapter is a mixture of some text, there's also some videos, there are worksheets, and then alongside that, each of the young people has a 30-minute chat session with what we call the therapeutic support worker. And we trained our master's students to deliver these, and that was a really interesting process for us. Just to give you a sort of a sense of what it looks like, we use the Swedish platform, the iTherapy platform. So you can see there the sort of the way the chapters are presented, and it gives you an idea of the kind of topics that the chapters cover. If you open up a chapter, that's sort of what the start of one of the chapters looks like. We actually, the young people we worked with on the cultural adaptation were really keen for this visually to look more different, that there were limitations to what the iTherapy platform would allow. This is an example of the kind of worksheets that the young people were asked to fill in normally at the end of each chapter, and then they could bring what they had written in the worksheets to the 30-minute chat sessions. Very briefly, the aims of our study fundamentally, first of all, was working with young people who are experts by experience in the cultural adaptation of the program itself. And then having done that, to really just test the feasibility of being able to deliver this online treatment and to collect some preliminary data on effectiveness. So we had 23 participants in this pilot study. And I think what was quite interesting, that the level of depression was really quite severe among this group. But more than half of them said they'd never received any formal mental health treatments before. And I put up on this slide just some of the reasons why young people said that they hadn't been able to seek help before. So for us, we clearly were reaching a group who otherwise had not been getting help, despite, as I say, quite severe levels of depression. I won't go through it, but these are some of the measures that we used. We, to some degree, tried to match the measures that have been used in the Swedish study. We're just doing our data analysis now, so I don't have a report on that, but it's looking really promising, particularly in terms of the impact on depression and emotion regulation, perhaps less so on anxiety, which is something we need to think about. We also managed to interview nearly all of the young people who were part of the study. Again, the analysis is just going on at the moment, so this is not a formal analysis. But I think one thing that came across in the interviews was that this didn't feel to young people like a second best treatment. This wasn't, since we can't have face-to-face treatment, this will have to do. There were a number of ways in which they actually saw this as a preferable way to get help, both in terms of the anonymity, in terms of the online and the accessibility of the program. And in terms of sort of their experiences of the program and how they felt it had impacted, I think it did seem to fit with the theoretical model, in as far as a lot of them talked about becoming more aware of their feelings, more accepting of their feelings, and increasing compassion in relation to their own emotional experiences. And I particularly like the quote there in the middle. I think the main thing is, if I'm feeling sad, I don't overanalyze it as much. And it's very nice in a psychodynamic treatment that an outcome is that they don't overanalyze, which is exactly how it should be. So we've obviously got a long way to go, but it feels like a really interesting journey that we've begun. Great, thank you.
That's wonderful. Thank you so much, Nick. It was really interesting, and Briony as well, for 2 really great talks. And I think I'm sure I speak for everyone saying that they'll be very stimulating for our discussions later. We've got a couple of minutes for Q&A. If anyone wants to stick a message in chat, or if you'd like to come on and ask a question of either of our speakers, feel free to do so now. Stella?
Yes, just kick it off. Now there's a new development that has been announced of every school have a kind of key mental health, and one of the teacher become the kind of mental health lead and have a small budget to send one teacher or so for some training. So just putting this work of both Briony's work and Nick's work, your team's work, or the other work you're aware of, like how would that fit in with this kind of with this new context of policy development? And do you think these new things about having, a key teacher and so, like, is that enough for, it sounds like it's not a lot. So I just want to see how that joined up, and what's your thought on that?
Yeah, I guess my immediate reaction would be it's probably not enough, but I think it is important and useful. So one of the themes that came out of the review looking at facilitators to implementation was about support from senior leadership. And we went on, after doing this review, to do a small feasibility study within schools and colleges, looking at delivering an intervention for early features of BPD. And we did find that bore out, I guess, schools where there was a real advocate intervention for mental health support within the school. It was a lot easier to get things done. So I think if that person can play that role of being an advocate and making sure that mental health support is prioritised, that could be really important. But I think, that on its own, I think there needs to be people on the ground as well who can actually deliver the support. And that one member of the senior leadership team is probably not going to be that person. I thought.
Great, thanks, Briony. Nick, do you want to pick up and then we'll go to Shirley?
Just to echo what Briony said, I think there is a danger that sometimes the debates become an either or. Either we focus on psychological treatments and specialist CAM services, or we focus on early intervention in schools. And I think if we can find a way in the dialogue around this to keep both of those in play, we clearly need early intervention. Schools have a huge part, but clearly that's not going to be sufficient in itself. But working from both sides, I think, is what's most important.
Great, thanks, Nick. Shirley?
Well, I just wanted to add something to what Stella was saying about the mental health champions, the teachers in schools. There are also a new breed of workers called educational mental health practitioners, EMHPs, who are low intensity workers who each school should get one in England after the programme rolls out. And I mean, this brings me to Nick's intervention, really, because actually what you've got there is an intervention that these people would be perfect to support. Although I do think, like you suggested, Nick, that's not the most useful interface for some of the children we'll see who have problems with literacy and text-based information. So I think there are issues there about implementation and how that would work really in most comprehensive schools. However, I think the actual model really gives us something really new to think about, and it's great to have alternatives to what are typically CBT-based interventions. So there is hope. I think there is hope for both CAMS and school-based interventions. It's just kind of getting the workforce out there really now, isn't it?
I don't know what it says about Swedish teenagers, but the text of the Swedish version, there was a lot of reading material, and the Swedes said no. All of the young people who took part in the study, they read all of it. But when we worked with our experts by experience, they said too much.
Funnily enough, I looked at the Swedish platform myself and had exactly the same feedback from young people. And when we delivered our own materials, they were all simpler, fewer words, more pictures, less talk. It's always the same. So yeah, I think Sweden just has higher literacy levels than we do, clearly.
So there's another question in the chat, Nick, targeted at your presentation. So this is from Claire Ballard, and she said, were the adolescents in your study neurotypical, or do you know if any had conditions such as ADHD or ASD?
It's an interesting one, Claire, thank you. So in the Swedish study, ASD was one of their exclusion criteria, a diagnosis of ASD. And I think we were keen to sort of widen that, but they felt quite strongly that the program had been developed and that it hadn't yet been tested for young people with the diagnosis of ASD. So that was an exclusion criteria for our pilot study. And I think we would like to, in the next phase, sort of explore, what would need to be adapted to the programme to make it appropriate for a wider group of young people.
Great, thanks, Nick. We've probably got time for one more question.
Just say, I'd be interested to hear Claire's thoughts, because it was quite a debate we had with the Swedish team, and if she has thoughts on that, I would welcome it.
Claire, is there anything you wanted to pick up? Feel free to come on mic or comment in chat.
Hi, sorry. Thanks for that. That's really interesting. Yeah, the reason I asked is I work in a team who are looking at developing interventions for adolescents with ADHD and ASD, specifically with the goal of reducing the prevalence of depression, which is quite high in those groups. And so that's why I was quite interested as to whether any had been included in your sample.
Maybe we'll have to come and consult with you.
Could I just quickly say, Claire, do you know about Ailsa Russell's work?
No, I don't know.
Ailsa has been doing work on adapting current interventions for young people with ASD, not ADHD so much, but ASD. So it might be worth checking out. I think she at the Institute of Psychiatry, Tori, these days. She was.
She was. I'm not sure she is anymore. I think she might be at Maria Shipbar.
Yes, she's at Bath as part of the Centre for Applied Autism Research. I will put a link to her bio into the chat right now.
Oh, fantastic. Thank you. That's really helpful. Thanks, Dave.
There are other people out there working on this,
yeah.
Thankfully, because it is a big area, isn't it?
Yes, yeah.
There's also that work by Suzanne Bogles on mindfulness with children with ADHD. I don't know if you know about that. I mean, it's intriguing. I don't know, but that's curious and fascinating, and their parents as well.
Yeah.
Right, lovely. Thank you so much. That was really, really interesting and nice discussion as well there to wrap up. So we've got one more presentation before we take a little break. So I'm going to introduce Georgia now, who's our lived experience researcher. And Georgia's going to be presenting findings from a survey that we took to young people with lived experience about how we approach interventions in young people with depression. Thanks, Georgia.
Thanks, Faith. Hello everyone, my name's Georgia Herring and I'm part of the ADvaNCE group. Some of you may remember me from our workshop last month where I presented young people's perspectives on how to better identify depression in young people. So my role is as a lived experience researcher, so this means I support the team in planning and running the workshops and offer a lived experience perspective to help make sure the work we do is meaningful and engaging to young people. So today I'll be talking through the next segment of our young people survey, which focused on our second priority, which is what are the best early interventions for adolescent depression and how early should interventions be facilitated to ensure the best patient outcomes. So young people's perspectives are really important in order to guide research directions in a meaningful and helpful way, and ultimately improve how we treat depression in young people. To gain young people's perspectives, we created the Young People's Have Your Say survey. We contacted young people's advisory groups who distributed the survey to young people aged 16 to 24 to complete on a voluntary basis. This section of the survey focused on three components of interventions. The first component is what. So what do young people think is helpful or unhelpful for interventions to focus on? Secondly, where. So where should the interventions take place, whether this be on a digital platform, in groups, or on a one-to-one basis? And thirdly, when. So how early should interventions be facilitated? We've been able to collect both quantitative and qualitative perspectives from the survey. For those of you who might not be familiar with this terminology, this means we were able to gather numerical and written information. So when we asked young people, what do you think young people experiencing depression or low mood would find helpful for psychological interventions to focus on? The component which young people rated as being very helpful, as illustrated by the completely blue and green bar on the left, was being able to talk about their difficulties without judgment. As you can see, although all the components were rated as being more helpful than they were unhelpful, the components which received minority unhelpful and very unhelpful ratings, as illustrated by yellow and red, were how your thoughts, feelings and behaviour impact on your mood, setting clear goals you can work towards, and learning to be kinder to yourself. As you'll see in a following slide, one young person expressed they did not find the structure of CBT helpful, so this might explain these minority unhelpful ratings of certain components which they may have experienced in their experience of therapy. These are some responses from young people when they were asked to add, if they'd like to add anything that they think might be helpful for interventions to focus on. One young person said, how to safely deal with your emotions and express them to the outside world. Another young person said, from my personal experience, I find CBT-based help not particularly helpful. I never managed to get to the root of my problem because the focus would always be on homework and goals, which would cause me more anxiety. And as it never actually got to the root of my problems, any success from it was quickly lost as soon as I stopped. When we asked how helpful they thought types of interventions would be for a young person experiencing depression or low mood, the options which young people expressed as being very helpful, as illustrated by the green bars, and helpful, as illustrated in blue, were individual and school-based interventions, which young people rated as being most helpful compared to other types of interventions. Family-based and digital platform interventions were perceived as being less helpful, as illustrated by the yellow and red segments of the bars. Although young people have expressed exploring relationships with friends and family would be a helpful component for therapy to focus on, it was seen as less helpful as an intervention compared to other interventions. These are some quotes from young people when they were asked, why do you think the option you rated the most helpful would be helpful for adolescents experiencing depression and low mood? One young person who rated school-based interventions as most helpful said, I think it's important to trust a particular person and be able to regularly communicate with them. If this is in school, then it makes them a little more accessible and also means teachers can be made aware of additional support academically if needed. A young person who rated group-based interventions as most helpful said, it exposes them to the idea that they are not the only ones dealing with depression and that there are indeed others who feel like they are in the same place. Therefore, they would find it safer and easier to bear all. And a young person who rated individual-based interventions as being most helpful expressed they would feel there would be no judgment. When we asked young people when they thought young people would be first most willing to receive support for depression and low mood, young people jointly rated when they start to experience difficulties and when they struggle to cope day to day as being most appropriate times to receive interventions, as opposed to once diagnosed with depression and before they experience depression. These are some responses from young people when we asked, why do you think the option that you chose is the time where young people would be most willing to receive support? A young person who rated when they start to experience difficulties as being most helpful said, this would help the issue before it escalates into something that would be harder to support. Being aware of depression before they experience it would be important, but this could possibly impose the issue of people mistaking other issues, for example, being upset after disagreements, short periods of sadness, for depression. A young person who rated when they struggle to cope day to day as a time that the young person would be most willing to receive support said, because when they struggle from day to day, that's when they realise they're not okay and that they need support. And two young people who rated once diagnosed with depression said, as humans, we tend to ignore a problem and seek help for said problem until the problem is staring us in the face, unable to be ignored. Not knowing they have depression, live with it so long it has become normal and accepted as part of their life. not feeling worthy to have a better life. We're now moving on to the discussion section of today's workshop. We'll be going into breakout rooms shortly, and each breakout room will have an advanced group member coordinating the discussion. So in your groups, we'd like you to discuss, based on the talks today, what changes could be made in the way we treat depression or low mood in young people. We'd like you to generate 2 suggestions or 2 solutions for how we might take this work forward. So this could focus on the what, intervention focus, the where, the context of the intervention, or the when, how early to facilitate an intervention. We'll be returning to the main room from the breakout rooms at 10:35, and that's when your group coordinator will share your group solutions with the wider group. But before we move on to the discussion, if we'd like to just take a 5-minute break, and then when you return, you should be all sorted into your breakout rooms. Thank you.
Thanks so much, Georgia. Just to quickly comment to say we'll probably push the breakout rooms to end at 10:40 for those members, but I'll send a note to let you know when they're done. But yeah, thank you. Do take a break and I'll set up the breakout rooms now.